So I'm going to talk about point of care troponin testing, some of the research that we've been doing, the sort of groundswell of evidence that there is for this, and some of the great promise that it has for us in emergency care, as well as some of the challenges that we're going to have to overcome to get this into mainstream practice. So this is about care in emergency departments, which is where I work at Manchester Royal Infirmary, and year on year, quite some time, we've faced an increase in emergency department crowding. There's been rising attendances, and in recent years, even though that sort of trajectory's stabilised a little bit, the patients that are attending are more complex, they're older, so we really have a significant problem with crowding. And crowding isn't just an issue of discomfort for patients. It's been proven time and time again to increase deaths, to increase costs. Healthcare costs increase when we've got crowding in the emergency department. We have more patient safety incidents when we've got crowding, and patients stay longer in the hospital when they've been admitted through periods of emergency department crowding. And just to emphasise that point about mortality, this graph shows the standardised mortality rate of patients who attended an emergency department according to how long they stayed in the emergency department. And you can see that once you get to about 4 hours, we have that magical 4-hour target, right, in emergency departments that we fail to hit. But once you get to about 4 hours, the standardised mortality rate is going up, and it increases steadily ever since. The longer you stay in an emergency department, the more likely you are to die. And it's estimated that this has caused 16,000 excess deaths in 2024 alone. 16,000. Imagine how many plane crashes that would take to cause 16,000 deaths. That's a huge amount. It's a really significant problem. One of the big problems that causes crowding is exit block. And if we get rid of exit block, that would be fantastic. Patients who need admission can't find a bed to go in. But diagnostics is also really important because it can help our flow through the department. It's critical. One of the most critical things that we do in emergency medicine is diagnose patients. And to do that, we need tests. So, for example, if a patient has symptoms of a possible pulmonary embolism or DVT, we more often than not need a D-dimer test. For myocardial infarction, we'll need a troponin test to decide if they've got a myocardial infarction or not. Or if they've got sepsis, we might need a CRP or a procalcitonin test. And we've got to wait for those, and we can't act on them. We can't admit the patient. We can't discharge them until we've got the test results. So the quicker we can get the test results back, in theory, the quicker we can process patients and the more flow we get. I'd like to focus now on chest pain and the problem that we particularly have with chest pain. So about 1 in 20 people who attend the emergency department will have a main complaint of chest pain. That's around about 1.3 million people attending emergency departments every year across the country. And of those patients where we suspect it might be caused by a heart attack, about 10% of them actually do have a myocardial infarction or a heart attack. So 90% of people have negative tests, and in the vast majority of them, they could actually just go home, probably indigestion or muscular pain. It's not anything serious that requires hospital care, but we didn't know that. They've got to have the tests. And it can be really hard based on the symptoms to decide if it's a heart attack or not. William Osler once said, there is no condition more calculated to maintain one of a wholesome state of humility as angina of the heart. And he went on to describe a case of a woman he diagnosed with hysterical angina. Thankfully, that's now gone from our diagnostic armory. But she went on to have a myocardial infarction, it seems. And that's because patients can present with such vague, apparently mild symptoms, 5-10 minutes of mild discomfort, and it's a heart attack. And meanwhile, someone else comes in with crushing chest pain going to the left arm when it's not a heart attack. So we need the tests. Fortunately, we've got really good tests in the lab now. So we measure troponin, which is a protein that is only contained in the heart muscle. And when it spills out into the circulation, it's a clear sign that you've got a heart injury. And we can measure this accurately with very small concentrations using high sensitivity troponin tests. And over the last 10-15 years, we've made amazing progress. We used to keep people in for 12 hours to do tests. And now, with the first test, if you've got a very low troponin level, we can say it's not a heart attack. No more tests needed. That applies to maybe about a third of the patients. If we use a risk score, like the heart score or Tmax, which we developed in Manchester, you can get even more people reassured following the first test. 40% or more patients can be reassured, and you can risk stratify everyone as well. For those people you didn't identify on the first test as saying it's definitely not a heart attack, you can do a second one just an hour later. And if the levels are changing very little, then you can also say it's not a heart attack. So no more 12-hour tests. You can do the test on arrival, 40% of people out, 1 hour later for the rest, 70% of people out. Fantastic, problem solved, except it's not. So we did a big study. I was involved with this, but it was driven by our trainee emergency research network in emergency medicine across the country. 94 hospitals took part, over 8,000 participants, and they collected data about the care of patients who had a suspected myocardial infarction. And the graph on the right shows the results aggregated by hospital. So these are hospitals where they did the new pathway. 0, 1. I don't know if you can see my arrow, you can't, can you? At the top it's 0, 1. So you did the test on arrival, and just like I said, the second one's an hour later. Some hospitals did 0, 2, so the second test is 2 hours later. Some went all the way to 12 hours, like the old days, doing the test 12 hours after arrival. Now you would think that if you do the test 12 hours after arrival, that's going to mean that you're staying longer in the hospital, except it didn't. Those coloured bars show the length of stay, and what you can see is the length of stay doesn't change, depending on the department's protocol. So we're implementing these rapid rule-out protocols, and they should be working. If you get a test at 1 hour, you should go home a lot sooner than if you had the test at 12 hours, but you're not. So why not? Well, maybe it's because we're sending all the tests off to the lab, and it takes a long time for the results to come back, and no one's acting on them for a while. Perhaps that's got something to do with it. And now, industry, and we've got ASIM here, companies have developed high sensitivity point of care troponin tests that give us lab quality results at the bedside with a very short turnaround time. No more 1 to 2 hour waits for results. You can get this result in 10, 15 minutes. So you've got the lab quality, but does it work? Well, the first check of that is to do accuracy studies, and they're on the way, and the evidence is really coming. I'll tell you about one of ours that's we're just about to press go on to submit to a journal. It's called the Best 2 study, which I led, and we recruited patients at 7 emergency departments across the country, including a total of 683 people. So they all had troponin tests at the point of care. This is the Siemens Atellica VTLI test here, which gives you a result in 8.5 minutes. Sorry, top corner. And we wanted to know how accurate that was against the lab tests and an adjudicated diagnosis. So here you can see, if you just use troponin by itself at a low level, you've got 98% of people with a heart attack being detected. That's the sensitivity. Negative predictive value tells us if your test was negative, what was the chance you had a heart attack? Well, 99.2% of the time it was right. So only 0.8% of the time, if you had a negative test, it was actually a heart attack. And Tmax was just the same. So we've got really good data coming out that suggests that these tests not only give you lab quality measurements, but it translates to diagnostic accuracy as well. The next question now is, what happens if you use it in practice? Will it actually make a difference to patient care? And will we get reduced length of stay? Well, I've been involved as an external collaborator in 2 randomized controlled trials that have recently got their results out. This one's not reported in journals yet, only as an abstract. One was in Norway. In Norway, they didn't show that the low-risk patients got home quicker, but high-risk patients got to cardiology wards quicker. You wouldn't think it was that way around, but that's how it worked in Norway. In New Zealand, they did a massive trial. It's called Stepped Wedge, 7 emergency departments, and all of them started on routine care doing lab tests. And then month by month, the sites switched across until everyone was using the point of care tests, and they could compare length of stay. So there were 31,000 people in this trial. And the odds ratio of getting home within 6 hours, if you had a point of care test, was 2.4. So you're twice as likely, more than twice as likely, to stay less than 6 hours if you got the point of care testing pathway. And there was on average a 2.9 hour reduction in the length of stay. So it really worked in New Zealand. In the patients who didn't have acute coronary syndrome, it didn't make much difference for the people who did. But this is where we're trying to influence it. So if you didn't have a heart attack, we were effectively shortening your length of stay. So how would that work in the UK, and what are the challenges we've got to overcome? Well, here's a typical pathway of what might happen for a patient who comes through the emergency department. They have their ECG at 10 minutes, first test that we do, and then the blood tests might be done after, say, half an hour. Now, the result's not going to come back from the lab for an hour or two. We'd take that second test an hour later, but 40% of patients don't need it. And we're not going to get the result till 120 to 135 minutes. So do you take the second test? If you do that, the 40% of people who could have gone home with your single test have now got to wait for a second test. So you've lost the benefits of your single test rule out. And we're really getting far into your journey by the time you get your result. If you wait till you've got your result, so the patient's going to be waiting a long, long time. And it really won't matter how long the test result is taking if you don't have a doctor or clinician seeing the patient for 3 to 8 hours, as is happening quite often right now. So how would it work? I think you need to bring the clinician assessment right forward. So we do the blood test at the front door, you get your result in minutes, but then it needs to be acted on. And that's what we really need to rethink. So it's not just about buying the tech and putting it in a department, but to rethink the pathway. So we could have a rapid assessment model where a senior clinician is based at the front door and they're tasked with deciding who needs the test. And then if they have a test, they don't move on from the rapid assessment until you've seen the result and acted on it. And that way, you don't get people in a long queue with a test result when they could have been allowed to go home or referred to cardiology early. Another thing we could do is triage to same-day emergency care units. Every emergency department has a co-located same-day emergency care unit now. They're ambulatory care areas. And if we identify a patient as being low risk at the front door, then we could triage them to the STEC unit away from the main emergency department, which is so crowded. And they could be safely seen there and hopefully efficiently cared for. And then the last thing I wanted to raise is one of the big challenges we've got to think through is who does the tests. So at the moment, lab tests are done by biomedical scientists, professionals, done to a high quality. We know if you give tests to support workers, nurses, doctors, definitely don't do it to doctors, the quality goes down. The tests aren't done for the same quality and the results aren't the same. As a result, you get more failures, etc. Could we have biomedical scientists doing a hot lab in the emergency department to run this to a high quality, just as you have in the lab? So in summary, I mentioned that ED crowding is a significant problem. It causes about 16,000 excess deaths a year, and that's something we've got to address quickly. Point of care testing could address this by expediting diagnosis, but it's not as simple as just buying the kit and putting it in and expecting it to work. We've got to redesign the whole care pathway in order for it to work. Thank you very much.